The stomach develops as an outpouching of the foregut. Its blood supply comes from the celiac artery. During fetal life, the organ rotates anti-clockwise along its longitudinal axis. Its right side becomes dorsal and its left side ventral. The ventral mesogastrium develops into the falciform ligament, the liver, the hepatogastric, and hepatoduodenal ligament. The dorsal mesogastrium develops into the great omentum, the gastrosplenic, and the gastrocolic ligament. Finally, the peritoneal cavity is divided into the space in front of the stomach, commonly called greater sac, and the space behind the stomach, commonly called lesser sac. These two spaces communicate through the epiploic foramen of Winslow. Topographic landmarks of the stomach are the lesser curvature, cardia, fundus, body, great curvature, antrum, and pylorus. In the right part of the slide, we can see the stomach opened. The gastric folds, also called rugae, are more prominent in the fundus and the body, and less prominent in the antrum. Of topographic importance are also the cardiac notch and the incisura. The same landmarks can also be seen radiologically in simple and double contrast. Esophagus, E. Cardia, fundus, body, B. Antrum, A. Pylorus, P. The first part of the duodenum, also called duodenal bulb, DB, and jejunum, J. The gastric folds can be clearly seen in the right part of the slide. The stomach is supplied by the celiac artery. This gives three branches, the left gastric artery coursing along the lesser curvature. The second branch is the common hepatic artery, from which the gastroduodenal artery and the right gastric artery arise. The right gastric artery courses along the lesser curvature to meet the left gastric. Thus, an arterial arcade is created. The gastroduodenal artery courses across the first part of the duodenum on the head of the pancreas, giving rise to the superior pancreatoduodenal and the right gastroepiploic artery. This courses along the greater curvature supplying the stomach and the omentum. The third branch of the celiac artery, the splenic artery, courses dorsally and cranially to the pancreas to give the left gastroepiploic artery. This, in turn, travels along the great curvature supplying the stomach and omentum. Anastomosing with the right gastroepiploic artery, it creates another arterial arcade. Finally, the splenic artery gives rise to branches towards the spleen and the short gastric vessels which supply the gastric fundus. Of surgical importance are also the posterior gastric artery, a branch of the splenic artery, and the supraduodenal artery, a branch of gastroduodenal artery. The veins of the stomach follow the same course with the arteries. The left gastric vein and the right gastric vein travel along the lesser curvature, and together they form the coronary vein, which drains to the portal vein on either side. The left gastrepiploic vein and the short gastric veins drain to the splenic vein and finally to the portal vein. On the other hand, the right gastrepiploic vein joins the anterior inferior pancreatoduodenal vein and the right colic vein to form the gastrocolic trunk, which drains to the portal vein through the superior mesenteric vein. Lymph returns to the blood circulatory system with the lymphatic vessels. Along them lie lymph nodes, which we classify into three tiers. Nodes of the first tier are commonly referred to as the perigastric lymph nodes. These are receiving lymph coming from the stomach and includes the left and right pericardial nodes, the nodes along the great and lesser curvature, and the supra and subpyloric nodes. From the perigastric nodes, lymph flows to the nodes of the second tier, which lie along the major gastric blood vessels. These include the nodes of the left gastric, common hepatic, hepatic proper, splenic, and celiac arteries. Lymph flow goes on towards the third tier, which practically includes the preaortic nodes, the aortocaval nodes, and the nodes lateral to the aorta, from the renal vein to the origin of inferior mesenteric artery. Then, lymph passes through the cisterna chyli and the thoracic duct to return to blood circulation. In this slide, where the stomach is lifted up after dividing the gastrocolic ligament and we entered the lesser sac, we can see the perigastric lymph nodes of the first tier in yellow. Removal of these nodes is considered a D1 lymphadenectomy. The second tier is marked with green color, and its removal represents a D2 lymphadenectomy. The third tier, i.e. the paraortic nodes, is colored red, and its removal represents a D3 lymphadenectomy. The stomach is innervated by the autonomous nervous system. The sympathetic nervous fibers derive from the T6 to T9 spinal cord segments, pass through the greater splachnic nerve, and end in the celiac plexus. Following the periarterial plexuses, they reach the stomach to control the vascular tone, to increase the tone of the pyloric sphincter, and to relax the rest of the stomach. Parasympathetic innervation is mostly mediated through the vagus nerves. These control the secretion of acid from parietal cells and of mucus from the pyloric mucus glands. Vagal stimulation relaxes pyloric sphincter, while it increases contractility of the rest stomach. The left and right vagus nerves enter the thoracic cavity, travel as a periesophageal plexus along esophagus, and finally form the anterior and posterior vagus nerves. Practically, these correspond to the left and right vagus due to the embryonic 90 degrees rotation of the stomach. By entering the abdomen, the anterior vagus gives hepatic and gastric branches, while the posterior vagus gives intestinal and gastric branches. As a result, there are two nerves passing through the hiatus. In the case of a more cephalic bifurcation, 4 nerves are passing through the hiatus. Or, when the periesophageal plexus is lower, more nerves are seen in the hiatus. These variations should be taken under consideration when we denervate the stomach performing a vagotomy. Of particular importance is the pyloric branch of the hepatic branch of the anterior vagus nerve, which relaxes pyloric sphincter, allowing gastric emptying in 70% of the patients, even after selective vagotomy. Gastric wall is composed of mucosa, submucosa, the muscle layer, and serosa. The first layer of mucosa is epithelium, which is separated from the underlying lamina propria by the basic membrane, and significant barrier in malignancy spread. The next layer is muscularis mucosa, which restricts the infiltration of submucosa by malignancy. This is important due to the extensive network of lymph and blood vessels that exist in the submucosa. Infiltration of these networks increases the chance of cancer spread. In contrast to the rest digestive tract, muscularis propria is composed of 3 muscles, the inner oblique, the circular, and the outer longitudinal. The structure of the gastric wall can be clearly visualized with endoscopic ultrasound. The 2 muscle layers, the muscularis mucosa and the muscularis propria, are rich in myosin and can be seen lying between the 3 layers of mucosa, submucosa, and serosa together with perigastric tissue, which are rich in water and carbohydrates. The whole picture resembles a double hamburger with the 2 muscular layers resembling meat, just as the 2 burgers, as opposed by the 3 layers rich in carbohydrates, just like bread. Gastric mucosa is lined with various cells and is characterized by the existence of glands and pits. There is a difference among the products of the cardiac, the fundic, and the pyloric glands. This is due to the difference of the cells that constitute the glands with regards to their location. The most common cells are the mucus-producing ones, the parietal cells which produce acid, the chief cells which produce pepsinogen, endocrine cells producing various hormones, and progenitor cells which multiply and differentiate to the other kinds of cells. Under magnification, we can see that mucus-producing cells are located on the surface, while parietal cells are located in the pit neck, and chief cells are on the bottom of the pit. Gastric motility is mediated by a pacemaker located at the middle of the great curvature towards the antrum. It causes approximately 3 contractions of the gastric musculature per minute. The fasting stomach undergoes a self-cleaning cyclic procedure every 1 or 2 hours, called migrating motor complex. Each cycle begins with quiescence as phase 1. In phase 2, there are irregular wall contractions. The cycle ends with the 3rd phase, which is a burst of phasic propagating contractions. This cycle serves as the stomach's housekeeper. The upper part of the stomach functions as a reservoir. Food intake abolishes the cyclic MMCs and activates receptive relaxation. This is a reflex mediated by vagus, which relaxes the muscles of the fundus, allowing the accommodation of food, without increase of intragastric pressure. Vagotomy abolishes this reflex, which explains the early satiety even if the stomach itself remains intact. The distal stomach acts as a pump and a mixer. With food in the stomach, antral contractions lead to peristaltic waves of 100 millimeters of mercury, pushing gastric content towards the pylorus. If this is open, the food passes to the duodenum, otherwise it bounces backwards and mixes. Gastric emptying is mediated by the coordinated actions of central nervous system, with local and regional, neural and hormonal control. Food intake causes receptive relaxation to accommodate the food in the fundus. Increase of intragastric pressure activates pressure-sensitive receptors, which in turn activate the vagus nerve and various inherent gastrogastric reflexes. These increase gastric peristalsis, aiming to empty the stomach. On the same time, secretion of gastrin increases further antral peristalsis in combination with vagus nerve action. Food in the duodenum and duodenal distension exert a negative influence on gastric emptying. Fat, or protein, or acid, or increased osmolarity in the duodenal lumen all delay gastric emptying. This is achieved by the activation of an inhibitory duodenogastric reflex, as well as the secretion of hormones like secretin, cholecystokinin, and gastrointestinal polypeptide, which also inhibit gastric motility. The outcome is a delay of gastric emptying. The major function of the stomach is the production of acid necessary for food digestion. Basal acid output, BAO, is the acid secreted in fasting stomach, and it is estimated to be 2 to 5 milliequivalents per HR. When there is food in the stomach, the acid output becomes approximately 3 times the basic one. Maximal acid output, MAO, is total acid secretion after administration of a gastric stimulant that cannot be increased by higher doses. Peak acid output, PEO, the highest rate of gastric acid secretion that can be achieved after injection of a gastric stimulant. Traditionally, we classify acid secretion into 3 phases. The cephalic, which is under the influence of the central nervous system and the vagus nerve. The gastric, which is neurally or hormonally controlled from the stomach itself. And the intestinal, which is controlled by the small intestine and the duodenum. During the cephalic phase, the vagus nerve stimulates parietal cells to secrete acid by M3 muscarinic receptors activation. Acetylcholine also activates the M1 receptors of the enterochromaffin cells, leading to release of histamine. This, in turn, activates the H2 receptors of the parietal cells, augmenting acid secretion. The action of acetylcholine is inhibited by atropine, which inhibits both M1 and M3 receptors non-selectively. Food in the stomach and gastric distension lead to gastrin release from the G cells of antrum, pylorus, and duodenum. Gastrin activates cholecystokinin 2 receptors of the parietal cells, causing acid secretion, but also of the enterochromaffin cells, causing histamine release with a subsequent secondary acid release through the H2 receptors of the parietal cells. Acetylcholine also binds on the M2 muscarinic receptors of the somatostatin secreting D cells. This causes somatostatin secretion, which abolishes acid secretion directly by inhibiting secretion from the parietal cells, and indirectly through inhibition of histamine release from the enterochromaffin cells. The stomach contributes to food digestion through pepsin also. This causes proteolysis and collageноlysis. Pepsinogen secretion is mediated by acetylcholine through M3 muscarinic receptors, cholecystokinin, and somatostatin. In acidic environment, pepsinogen is cleaved to pepsin, which is activated when pH is less than 4. Pepsin's action is maximized with a pH around 2. In pH higher than 5, pepsin is inactivated. And when pH exceeds 7, pepsin is disintegrated. Gastric mucosa is continuously exposed to a variety of harmful factors, either intrinsic like acid and pepsin, or external together with the food intake. Gastric acid and pepsin contribute to the defense against the external harmful factors, but gastric acid and pepsin are harmful themselves, so there must be a system protecting the stomach. This system is composed of various intraluminal factors like the epithelial lining, the mucus, the alkalic tide, the microcirculation, etc. The first line of defense is the mucus lining the stomach's mucosa, together with the various substances and the bicarbonates dissolved in it. Mucus is produced by mucus cells and has double function. First, it traps microparticles, and second, due to its hydrophobicity, especially when combined with the also hydrophobic phospholipids, it prevents the contact of hydrophilic acid with the cells of the gastric surface. The thickness of the mucus layer, and accordingly its defensive capability, increases when the stomach is distended or under the influence of cholinergic agents, gastrin, prostaglandins, and secretin. In contrast, pepsin, mucolytics, and nonsteroid anti-inflammatory drugs have mucolytic properties, while bile salts bind phospholipids. Bicarbonate ions are produced by carbonic anhydrase of epithelial cells. Their production amounts to 1/10 of acid and increases with the influence of acid, acetylcholine, prostaglandin E, corticotropin, melanotanin, and sucralfate. The second line of defense consists of the epithelial cells, which connect to each other with tight junctions, creating a mechanic barrier. At the same time, they synthesize and secrete a plethora of substances that contribute to the rest defensive systems. There is a continuous renewal of the cell population that requires from 4 days for epithelial cells to 30 days for glandular cells. Cell proliferation is affected by many factors, the main ones being the epidermal growth factor receptor, the transforming growth factor alpha, while cell apoptosis is affected by survivin. An important feature of the gastric mucosa is its ability to heal by reconstitution, i.e. by flattening and rearranging the remaining healthy cells to cover the deficits of the epithelium within a few hours. Typical healing that involves cell proliferation follows later. Alkaline tide is the simultaneous secretion from parietal cells of acid and bicarbonate, where the acid is secreted to the gastric lumen but the bicarbonate to blood circulation. Most of this bicarbonate is transferred away from the stomach, but a portion can be transferred with the capillary vessels towards the apical surface and thereof to the lumen. Considering the well-known stress ulcers which are due to microcirculation disorders, we can understand the importance of microcirculation in mucosal defense. Blood flow supplies mucosa with oxygen, nutrients, and bicarbonate, while it removes toxins and other harmful substances. Mucosal injury, or exposure to acid, leads to vasodilation and increase of blood flow. This is mediated by nitric oxide, prostacyclin, and hydrogen sulfide. In contrast, leukotriene C4, thromboxane A2, and endothelin lead to vasoconstriction. All the defensive mechanisms and intrinsic self-regulation pathways are mediated by a network of sensory neurons, which run in parallel with the capillaries directly under the epithelial cells. These neurons are activated by a pH drop and secrete a calcitonin gene-related peptide, CGRP, and substance P, which in turn lead to nitrous oxide secretion and vasodilation. There is a fine equilibrium between the offensive ability of the stomach through acid and pepsin and its defensive capabilities. Disruption of this equilibrium leads to the development of peptic ulcer disease.